Adolescent idiopathic scoliosis, AIS, is the most common form of childhood scoliosis involving patients of age 10 to 21 during their growth years and beyond the adolescent growth spurt. Girls are more likely to have curves requiring surgical treatment, although on occasion boys do as well. The traditional indications for surgery in this group is curves that are progressive or worsening over 40 degrees in a growing young person, or 50 degrees or more in a skeletally mature or someone who has reached the end of growth, or who have painful or worsening curvatures for patients of any age. The goals of surgical treatment include correction of deformity and prevention of future problems such as pain and breathing difficulties that occur with the most severe curvatures, and disability that can arise in the adult patient. And we do so in a way in which we preserve function and preserve as much motion and flexibility for the patient after surgery. Most of our patients return to sports and dancing if they are athletic after the surgery. We study the outcomes of surgery with patient questionnaires, so we measure how well the patient believes they have done as opposed to how the surgeon thinks they have done. Patients have been shown to have dramatic improvements in their body image and maintain function after scoliosis surgery. Typically, a spinal fusion is performed, usually from the back or a posterior approach, using titanium metal screws and cobalt chrome rods. This is combined with osteotomies or cutting into the bone to make the curvature more flexible to improve the correction of the spinal deformity. There are different grades of osteotomies ranging from simple cuts into the bone versus a complete resection, what we call a vertebral column resection, in which an entire vertebrae or two, these are the building blocks of the spine, are literally removed from the spinal column, and the spinal column is then reattached. And that is done for the most severe curvatures in which the spine is safely corrected, rather than trying to straighten out a very severely curved spine, because what happens then is the spinal cord is placed on stretch, and it increases the risk of paralysis with surgery. There are also cases in which VATS procedure is performed. A VATS procedure is video-assisted thoracoscopic surgery in which we use a scope and small incisions called portals to enter the thoracic spine, the ribbed portion of the spine, and remove discs to make the spine more flexible. This is a minimally invasive form of surgery that I have been one of the pioneers in for the last 20 years, and really helps to obtain a correction of a very severely curved spine in a safe way. We've also developed other new techniques to speed the recovery that occurs after surgery, limiting pain and bleeding and lowering infection rates. A new and very exciting area in AIS surgery is non-fusion or fusionless surgery. This is done through tethering or stapling of the spine, which has also been termed a flexible fusion, in which titanium screws are inserted through the side of the spine and attached with a tether, a flexible cable, that allows motion to be maintained as well as growth maintained, or it can be done with staples, small staples that span over the disc spaces and are used for smaller curves. These techniques are used for curvatures between 25 and up to 70 degrees.